Unicompartmental knee arthroplasty. Increased interest in less invasive surgical techniques has led to a resurgence in unicompartmental knee arthroplasty. Clinical outcomes and kinematic studies have determined that a successful unicompartmental knee arthroplasty functions closer to normal knee than a successful total knee arthroplasty. Types, there are two types: fixed bearing and mobile bearing. Fixed bearing, a historical standard of care. Mobile bearing, weight bearing through the meniscus increases the conformity and contact without increasing constraint, decrease in wear pattern, excellent survivorship out to the second decade. But technically demanding, bearings can dislocate. Both fixed and mobile bearing unicompartmental knee arthroplasties have excellent clinical outcome at more than 10 years. Indications are still controversial and vary widely from country to country. As an alternative to total knee arthroplasty or an osteotomy for unicompartmental disease, classically reserved for older people, lower demand and thin patients. 6% of patients meet above criteria with no contraindications. New effort to expand the indications to include younger patients and patients with a more moderate arthrosis. Contraindications: inflammatory arthritis like rheumatoid arthritis, ankylosing spondylitis are contraindications. AVCL deficiency, an absolute contraindications for mobile bearing unicondylar arthroplasty, and lateral UKA, controversial for medial fixed bearing. Fixed varus deformity of more than 10 degrees, fixed valgus deformity of more than 5 degrees, restricted motion arc of less than 90 degrees, flexion contracture of more than 5 to 10 degrees, previous meniscectomy in other compartment, tricompartmental arthritis, younger high activity patients and heavy laborers, overweight patients, grade 4 patellofemoral chondrosis are the contraindication for unicompartmental knee arthroplasty. Now we'll go through literature regarding unicompartmental knee arthroplasty. There was one study published in JBJ's 2011 on minimally invasive Oxford phase 3 unicompartmental knee replacement. A prospective study of 1000 phase 3 Oxford medial mobile bearing unicondylar arthroplasties performed with a minimally invasive techniques determined a 96% at 10-year survival rate when reoperation was considered a failure, and 99% survival at 10 years for revision of the components. HTO versus Uni, published in January 2017, JBGS. Alternative to UK include a proximal tibial osteotomy and total knee arthroplasty. In a comparative cohort study of 240 patients with isolated unicompartmental arthritis, those treated with the UK reached a higher level of activity early after surgery, which persisted at mid-term follow-up compared to patients who underwent a proximal tibial osteotomy. The UK group also had earlier but less frequent revision to total knee arthroplasty. Unicondylar knee arthroplasty versus total knee arthroplasty. When compared to unicondylar, patients who underwent a total arthroplasty had a higher post-operative morbidity in a multi-center study of more than 2000 patients. The authors recommended that the increased risk of perioperative complications after total knee arthroplasty should be considered when counseling patients who are appropriate candidates for either procedure. Conversion of unicondylar to total knee arthroplasty and total knee arthroplasty to revision total knee arthroplasty. The study was published in JBJ's 2016. A Norwegian arthroplasty register study of the outcomes of unicondylar arthroplasty after aseptic revision to total knee arthroplasty involving more than 1300 patients found that conversion of a total knee arthroplasty to revision total knee arthroplasty had a higher percentage of re-revisions due to deep infection compared to unicondylar knee arthroplasty to total knee arthroplasty conversions. However, the overall outcomes of both procedures were similar. Deep infection 16% versus 31% were major causes of re-revision for unicondylar knee arthroplasty to total knee arthroplasty versus total knee arthroplasty to revision total knee arthroplasty respectively. But the observed difference were not significant with the exception of deep infection, which was significantly greater in the total knee arthroplasty to revision total knee arthroplasty group. Impact of obesity. The impact of obesity and early failure of minimally invasive unicondylar knee arthroplasty was assessed in a study of 79 consecutive procedures with a minimum 2 years of follow-up. Failures was defined as a revision or a pending revision. A body mass index of more than 32 predicted failure and was associated with reduction in survivorship. Recent trends. Recent trends in unicondylar knee arthroplasty have involved robotic assistance and patient-specific resurfacing implants. Patient-specific implants and personalized jigs are designed on the basis of data from preoperative CT scan. The intent of such resurfacing implants is to restore normal anatomy and establish more normal kinematics. Patient-specific resurfacing implants can restore normal anatomy, the position of the joint line, and normal joint function, with the potential to result in more normal knee kinematics. Robotic assistance. A prospective randomized control study of 120 patients involving component positioning with a robotic assistance found that the proportion of patients with a component implantation within 2 degrees of the target position was significantly greater in the group that underwent robotic assisted unicondylar arthroplasty. It is unclear whether these positioning improvements translate into better clinical outcomes. Complications of unicondylar knee arthroplasty. Progression of osteoarthritis, component failure, component loosening, patellar impingement, polyethylene wear, infection, stiffness. Unicondylar knee arthroplasty has shown enduring long-term results and provides the potential for restoring more normal kinematics and thereby potentially enabling a more active lifestyle for patients. But patient selection is very important and technical expertise is must.